Hello, my dear learners. I hope you all are doing well. So, today I've thought to take you to a recall session. This recall session, which we will be covering all the Physiology INICET questions which were asked in your May 2023. So, without wasting time, let's get started. The first question which I got was, which amino acid is not used for hormone synthesis? So be very careful, इसमें जो not है उसको ध्यान में रखेंगे, because many times when we are reading the questions we just don't read the word not, and definitely then it is going to be a wrong answer. Options given were tyrosine, phenylalanine, tryptophan and glycine. So definitely we know that tryptophan is what is the 5-hydroxytryptamine or serotonin which is used. Tyrosine and phenylalanine, they are going to be important for the formation of catecholamines as well as dopamine, right? Tyrosine alone, if given, also you know that when tyrosine is iodinated, it is going to form your thyroid hormones, that is your T3, T4. So the correct option over here becomes glycine, that glycine is not used for hormone synthesis. So whenever you are having a question on hormone synthesis, remember you can categorize them first as those which are synthesized from the amino acid tyrosine that we've just seen. Second will be your steroids. All of them are synthesized from the common precursor, that is cholesterol, which will be your sex steroids, your adrenal cortex hormones and vitamin D. And third important one will be your protein polypeptide hormones. The protein polypeptide hormones are very important. These are the hormones which are PPP, that is the hormones of pituitary, pancreas and parathyroid. Pituitary, pancreas and parathyroid. These show something which is very important, that is called as regulated exocytosis. Regulated exocytosis means they are always synthesized as biologically inactive peptides. That means insulin will be synthesized as pre-proinsulin, proinsulin and then insulin, and all this processing is done in the Golgi apparatus and endoplasmic reticulum. Next, JAK-STAT hormone secretion is associated with which hormone? So you know that JAK-STAT is a kind of the mechanism of action of the hormones, right? So whenever you are speaking of endocrines, let me tell you very nicely that endocrines you also study with your medicine, but when it is physiology, remember the first chapter of Guyton where you are given the classification of hormones, the mechanism of action of hormones, their receptors is very important and is a repeated question that is being asked to you. So before I give you the correct answer, okay, let me tell you that you can classify the hormones as group 2, and because there is group 2, definitely there is going to be something which is group 1. These group 1 are your lipid soluble hormones, that is your steroids and your T3 especially I will speak, because it is the T3 that is going to penetrate the cell membrane barrier and bind to the nuclear receptors. These lipid soluble hormones have got a very long half-life because they are bounded to proteins. On the other hand, group 2 hormones are your protein hormones which have got receptors on the cell membrane or the cell surface. Because they are protein, they are not going to penetrate through the cell membrane. Now these can be classified as 2A, 2B, 2C and 2D depending upon their second messengers or the mechanism of action which they are going to adapt to. So cyclic AMP users are 2A, 2B are cyclic GMP users, IP3DAG 2C and enzyme linked are 2D. That means 2D hormones are those hormones which are not using any kind of second messenger, but they are using enzymes as their mechanism of action. Now which are those hormones? So these come as your 2D, which is insulin like growth factor, growth hormone and prolactin, out of which insulin like growth factor and even your leptin, they are using tyrosine kinase. Okay, they are using tyrosine kinase. whereas growth hormone and prolactin is using Janus kinase. Okay, Janus kinase, that is JAK-STAT. Okay, Janus kinase, that is JAK-STAT. One minute. This leptin is also using Janus kinase. Okay, leptin is also using Janus kinase, that is JAK-STAT. Insulin and insulin like growth factor, they use tyrosine kinase, and therefore the correct answer over here becomes leptin. Now aldosterone, because it is a steroid, definitely it is going to penetrate the cell membrane and bind to its cytoplasmic receptors and bring about genomic action, that is gene transcription and translation. Calcitonin, you can see over here that calcitonin is something which is going to use cyclic AMP as the second messenger. Okay, cyclic AMP as the second messenger. Now this is taken from a very standard book which you can refer, right? So this is this thing. Then what is used by vasopressin? Vasopressin has got different receptors. It has got receptors one which is V1A. This V1A mediates the vasoconstrictor effect. Okay, so V1A mediates the vasoconstrictor effect. V1A is also present in the liver and the brain, where it brings about glycogenolysis. Whereas the V1B, which is also called as the V3 receptor, this is present to the anterior pituitary, where it mediates the secretion of ACTH. So V1A and V1B, which we called as V3. Whereas the V2 receptor, okay, the V2 receptor, you can see over here, the V2 receptor is the one which is using G protein coupled mechanism and using cyclic AMP as the second messenger, is responsible for the water permeability action. That means when vasopressin has to cause vasoconstriction, it will use calcium as the second messenger, but when it has to bring about water permeability, it is going to use V2 receptor and cyclic AMP as the second messenger, right? So knowing the messengers is really very important as far as this general concept of endocrines is involved. Next one. Which of the following is going to stimulate your bitter taste? Options: alkaloids, aldehyde, amino acids, or HCl. So after a very long time, I am seeing a question that is actually coming on, this, that is your taste and smell, that is your special senses. So remember that there are, if you consider the taste, there are 5 primary taste. So initially we used to take only 4 that is sour, salt, bitter and sweet. These were supposed to be the 4 primary taste, but now the umami is also considered to be a primary taste sensation. So one very important correction. Second important thing, initially there was a taste map being given. According to the taste map, the tip of the tongue had a sweet taste, the back of the tongue is for bitter, anteriorly you have got salt, and posteriorly you have got sour. This misconception or this concept has now been modified, saying that although there is a taste map for the tongue, but every part of the tongue can be stimulated by each and every taste. Okay, so every part can be stimulated by each and every taste. This is something very important. Now when we speak of bitter, definitely bitters are going to be stimulated by alkaloids. Okay, so the bitters are mainly stimulated by alkaloids or by the organic substances, long chain organic substances that have got nitrogen. So remember, when we say caffeine, when we say strychnine, nicotine, all these are going to be stimulated by bitter, right? Whereas aldehydes, they are mainly going to bring about your sweet sensation. So aldehydes, ketone, alcohol, aldehydes, ketone, alcohol, sugar, glycols, they are for your sweet. HCl is definitely sourness. So the sourness depends upon the amount of hydrogen ions. More of them, more will be the sourness. Salty taste definitely is brought about mainly by your salt, that is by your sodium. As far as the amino acids are concerned, amino acids can also give a sweet taste. They can also give a sweet taste. Even small proteins can give a sweet taste. But when we speak of something which is umami, this umami taste is mainly because of L-glutamate, monosodium glutamate, that is coming from cheese, that is coming from the meat extract. Another very important thing in this particular aspect which you should know is the taste sensations, that is the salt and the sour. These are opening ionic channels, that means their mechanism of action is inotropic, whereas sweet, bitter and umami, these are acting through G proteins and therefore they are metabotropic, right? They are metabotropic, very important. Next one, cystic fibrosis is associated with mutation of which channel? So different options might be given to you, could be sodium, could be hydrogen, could be chloride, could be potassium and so on. So remember that cystic fibrosis, that is CFTR, is associated with mutation of chloride channel. Now this comes into the category which we called as channelopathies. So whenever there are mutations in the channels, they are categorized as channelopathies. These channelopathies can be either excitable channelopathies and non-excitable channelopathies. Excitable, for example, your myasthenia gravis, long QT syndrome, where the channels are associated with the excitable tissues. Non-excitable tissues like the cystic fibrosis and even your Bartter syndrome associated with kidney, where there is a mutation with the potassium chloride channels. So this is excitable and non-excitable channelopathies. Now this, cystic fibrosis is because of the mutation in the chloride channel that is located in the long arm of chromosome 7. It is associated with a defective mucociliary accelerator function, and the person is very much predisposed to pseudomonas infection. Whenever you are remembering the chloride channel, that is your CFTR, remember apart from the respiratory tract, this channel is also involved in the movement of the chloride ions into the intestinal lumen when you consider the pancreatic juice. So this CFTR channel study in your respiratory physiology as well as in your GIT, pancreatic secretion. Moving next. Now, the sarcomere order from lateral to medial is ZAHM, AZHM, MAZH or HAZM. Now you know that what is a sarcomere. So this is a sarcomere, which is actually the portion between two Z bands. So the sarcomere is supposed to be half I band plus A band plus half I band. That means on either side there is going to be half I band. In the center there is A band. This A band is consisting of nothing but the myosin, right? And in between this you have got this H zone, and between the H zone you have got this M line, right? Now the correct answer over here is A, that is ZAHM. ZAHM. So Z is the Z line, A is standing for actin, that is I band, H line and your M line. Okay, H line and your M line. So this is the H zone, basically H zone, and in center you've got the M line. So this is the electron microscopic picture. So please remember that these this question, electron microscopy, was also asked as a image related question. So this is important with your physiology of skeletal muscles. Now moving on next, another question which was regarded to the excitation contraction coupling in the skeletal muscle, and the question was asked that which of them is the correct answer. Options given were extracellular calcium does not play any role, intracellular calcium plays the main role, there is no role of calcium gated channels, or fourth option I could not get, maybe whatever it is. Now here the correct answer is that intracellular calcium plays main role as far as the skeletal muscles are concerned. If you look into the sarcotubular system of the skeletal muscle, you will see that there are long T tubules, and on either side of the T tubules you have got the L tubules. These T tubules have got DHP receptors which are voltage inducers, or they are the voltage sensors. This terminology, voltage sensor, is used only in the skeletal muscles, not in the cardiac muscles. So when the action potential will travel, this DHP receptors will open up because they are voltage sensors, and as they open up, they bring about a conformational change, and they open up these receptors, that is the ryanodine receptors, which are present on the L tubules. Ryanodine receptors are not voltage gated. It is just a kind of a lock and key conformation. So they are going to open the lock and the calcium is going to be poured. Whereas in the cardiac muscles, it is a calcium induced calcium release. That means this DHP receptors in the case of the cardiac muscles are actually containing or releasing calcium. So when the calcium is coming from this T tubules, it will bring about the release of more calcium from the L tubules. That is called as the calcium induced calcium coupling in the cardiac muscles. But in the skeletal muscles, the pure source of calcium is this L tubules, and there is also the calcium binding protein, which is chaliquestrin. Right? So the voltage sensors are exceptionally for your cardiac, for your skeletal muscles, and calcium induced calcium is mainly for your cardiac muscles. So remember that in the case of the skeletal muscles, the calcium that is coming from for the muscle contraction is totally from the sarcoplasmic, that is from the ICF, whereas in the cardiac muscle, 1/3 of the calcium is from the ICF, but 2/3 of the calcium is from the ECF. That means the amount of calcium that will come from the T tubules will allow more calcium to be released from the stored sarcoplasmic reticulum in the case of cardiac muscles. Whereas in the smooth muscles, if you will see, the source of calcium is mainly from the ECF. They have got very rudimentary calcium stores, right? They are present just in the form of like these calveoli. So the calcium will enter either through voltage gated calcium channels, mechanosensitive calcium channels, or there could be ligand gated calcium channels. The next question which had come was on the calculation of anion gap. I did not get the exact values, but let's see what is anion gap. So remember that the anion gap is something very important, which is only considered when we speak about metabolic acidosis. So it is not at all associated with alkalosis. The concept is that there are certain anions in the body which are unmeasured, okay, and that what creates to an anion gap, because normally the total number of cations should be equal to the total number of anions, but that is when we are using the word measured. But when we speak of unmeasured, we create a gap. That gap can be calculated as sodium chloride and bicarbonate, and we get this in the normal range of 8 to 16 milliequivalents per liter. So what is this anion gap? As I told you, this is only in the case of metabolic acidosis. Metabolic acidosis means there is a decrease in the bicarbonate ions. So if the body is losing, for example, 20 bicarbonate ions, the body has to compensate the electrical neutrality by increasing other anions. This anions could be either chloride, that means you either bring about increase in 20 chloride. So I have lost 20 anions, that was bicarbonate, so I am going to match this loss by increasing 20 chloride. Or I can, if the chlorides are not raised, I am going to raise any other anion. So when you are raising any another anion to compensate for the loss of bicarbonates, at that time you create an anion gap. That means at that time you are creating an increase in the amount of unmeasured anions. So whenever there is an increase in the anion gap, and the chloride will be normal, because this time what did you do? The loss in the bicarbonates was compensated by increasing other anions. अदर एनायंस मीन्स नॉट क्लोराइड, क्लोराइड को नॉर्मल रखा हुआ है बट उसके अलावा दूसरे एनायंस आपने बढ़ा दिए और बाइकार्बोनेट जो कम हुआ उसको हमने कॉम्पेंसेट किया. वेरी इंपॉर्टेंट कॉज इज डायबिटिक कीटोएसिडोसिस. Another condition is your normal anion gap. That means here the loss of the bicarbonates was compensated by increasing the chlorides, right? So this created to a normal anion gap. The very important causes becomes diarrhea and renal tubular acidosis. You get this question as in a very difficult form. Sometimes you are just asked to calculate anion gap, but sometimes you may be asked to calculate the anion gap and to diagnose whether it is normal chloremic or hyperchloremic, right? So this is very important question, acid base balance, for any exam you're going to give. The next question which was asked was I think a kind of a match the following, which was given with the GIT hormones. The hormones given were gastrin, motilin, secretin and CCK. So we'll just summarize the very important effect. As you know that gastrin, it is very important for increasing the gastric motility, as well as it causes increase in the gastric secretion. Apart from this, remember that it also causes increase in insulin, and it is trophic for the mucosa of the stomach and the intestine. Motilin is very important, not for motility, right? Not for the GIT motility, regular GIT motility, but it is important for the interdigestive movements, that is migratory motor complexes, which are also called as the housekeeper waves, which move at the speed of around 5 centimeter per minute to swipe out the GIT to prepare it for the next meal. So when you are in the well-fed condition, there will be peristalsis. But when it is an interdigestive period, the movements will be motilin, the MMC, which do not require enteric nervous system but require motilin. Secretin is a very important hormone because it is going to cause an alkaline rich secretion. An alkaline rich secretion especially of the pancreas and of the bile, because its function is to neutralize the acidity and augment the action of CCK. So bicarbonates and water will be increased by secretin, whereas cholecystokinin is going to bring about increase in the secretion of the pancreatic enzymes, which will bring about the digestion. So these two are very specific: secretin, alkaline, cholecystokinin enzymes, and both of them are again important because they decrease the gastric motility as well as gastric secretions. Apart from this, at the extra edge, cholecystokinin is a hormone that is also acting centrally, and it is bringing about satiety. So it is a hormone which is acting peripherally to bring about satiety. At the level of hypothalamus, you've got various neurotransmitters, neuropeptide Y, leptin, which take care of the feeding center, but peripherally it is your CCK. Moving next, relaxation pressure is zero at which lung volume? So when I speak of relaxation pressure, I mean to say end relaxation or end expiratory position. End expiratory position where there is total relaxation of the respiratory system, and there is going to be balancing of the elastic recoil of the chest and the lungs. You know that the lungs and the chest, they are elastic recoil structures having elastic recoil property which is functioning in the opposite direction, but that is well maintained at FRC. So this is the transpulmonary pressure. This is your FRC, which is balancing the elastic recoil property of the chest and of the lungs. So this is the relaxation curve of the entire respiratory system. This FRC, which is called as the relaxation volume, is also called as a buffer because it is the end expiratory volume at the end of tidal expiration, and it is still maintaining the partial pressure of gases despite of no fresh air being taken, right? And FRC is important because it is preventing the collapse of the lungs. Next question was, the Wind-Kessel effect is not shown by. So what is Wind-Kessel effect? Wind-Kessel effect is due to the elastic property of the arteries, which are rich in elastic structure. That means during systole they are going to stretch, and during diastole they are going to come back to their position, which will help in the flow of the blood during diastole, because diastole is using potential energy, systole is using kinetic energy and pushing the blood forward, but the blood will be moved forward during diastole because by this stored or this potential energy. This depends upon the arteries, which have got lots of elastic structure in their adventitia, because they can even have muscular build, right? There can be lots of muscles and there can be lots of elastic. So this elastic tissue is present in the aorta, subclavian and the common carotid artery. Radial artery does not show the Wind-Kessel effect, so the exception becomes the radial artery. Remember, these show the elastic recoil effect or the Wind-Kessel effect, stretching and coming back and responsible for the diastolic flow of blood. Now, this is a question which I have taken from the last INICET, and I'll correlate to the question which had come this time. In a 35-year-old patient, due to intravascular hemolysis, there is potassium risen to 5.5. What will happen to the RMP? Now see, when there is potassium which is more outside, see the normal range of potassium is 4 to 5, right? 4 to 5, and here we have raised the potassium. That means if already the potassium in the ECF is more, this potassium which is inside the cells will not move out, right? Because the movement of the potassium totally depends upon its concentration gradient. Now, because the potassium remains inside, the inside becomes positive. So the RMP becomes positive. That means the threshold to excitability decreases. The tissue becomes more excitable with hyperkalemia. That means increase in the potassium in the ECF. Opposite will take place when the potassium decreases. This time the question which was asked was something related to the Nernst potential. I could not get the question, but it was related to Nernst potential. Now, what is Nernst potential? See, suppose this is ICF and this is your ECF. All the ions, they can move in these directions, either from the ICF to ECF or from the ECF to ICF. That totally depends upon certain factors. So let us consider potassium. Potassium has got leaky channels, and therefore potassium can easily move from ICF to ECF. This is mainly because of its concentration gradient. The potassium concentration is more in the ICF, and so it moves out. Now, inside the cells there are negative ions which are your proteins. So as the potassium moves out, the inside positivity decreases because these are anions. So potassium has to come inside. This is its electrical gradient. So it can move out because of its concentration gradient, and it can move in because of its electrical gradient, and this is true for all the ions. Now there will come a point where the electrical gradient will become equal to the concentration gradient, and there will be no net diffusion of ions. There will be no net diffusion of ions. That point is the Nernst potential. So for the Nernst potential, it is important that we speak of the single ion, and the ion which we are speaking should be diffusible. So you cannot use this for non-diffusible ions. So when it is an equilibrium potential, that the concentration and the electrical gradient, they become equal to each other, and there is no net diffusion of ion, is the Nernst potential. The Nernst potential of potassium is nearest or contributing maximum to your RMP, because it is the potassium ion which is most diffusible at rest. Now this question which I have taken from the last INICET, there was an image which was given to you. This kind of an image was given to you, and the question was asked that there is a transport mechanism, and what is it? Simple diffusion, facilitated primary active transport, or secondary active transport. Now you can see that there is a conformational change taking place, and there is use of a carrier protein. So definitely this becomes our facilitated diffusion, right? This becomes our facilitated diffusion. though there is carrier protein, there is no usage of energy. This is differentiating the facilitated diffusion from the SGLT, that is the secondary coactive transport mechanisms. So remember, GLUT is facilitated diffusion, but SGLT is secondary coactive transport mechanism. Right? So this is all for the questions INICT recall I could get from my side. If you have got anything else to share, please share so that we can discuss it more. And I'm going to provide this notes in the form of a PDF on my Telegram group, that is Physiology Synapse to Success. That's all from your mentor. Thank you and happy learning.